Cardiovascular toxicity of cocaine, diagnosis and evidence-based management. Cocaine-related cardiovascular emergencies account for an estimated 1.5% of all acute coronary syndromes and generate greater than $2.5 billion in healthcare costs annually in the United States. The drug's potent inhibition of norepinephrine reuptake produces acute coronary vasospasm, platelet activation, and proarrhythmic catecholamine surges. Rapid diagnosis hinges on a combination of plasma cocaine level, greater than 0.5 mg per liter confirms toxicity, high-sensitivity troponin elevation, greater than 0.04 nanograms per milliliter, and ECG patterns of ST segment deviation or QTc prolongation, greater than 460 milliseconds. First-line therapy combines benzodiazepines, diazepam 5 to 10 mg with nitrates and calcium channel blockers, while avoiding beta blockade unless combined with alpha blockade per AHA/ACC 2021 ACS guidelines. Key points. Note, cocaine-associated acute coronary syndrome, ACS, occurs in 1.5% of all ACS presentations, with a relative risk, RR, of 2.5 for myocardial infarction, MI, in chronic users. Plasma cocaine concentration greater than 0.5 mg per liter, measured by gas chromatography, mass spectrometry, correlates with a 92% sensitivity for clinically significant toxicity. Acute hypertension, 180/110 mmHg, is present in 68% of cocaine-related emergencies. A systolic greater than 200 mm of mercury predicts a four-fold increase in aortic dissection risk. Intravenous diazepam 5 to 10 mg Q5 15-minute, max 30 mg per hour, reduces catecholamine surge by an average of 45% within 30 minutes, p less than 0.001. Sublingual nitroglycerin 0.4 mg Q5-minute, max 3 mg per hour, resolves coronary vasospasm in 78% of cases, with a mean time to ST segment normalization of 12 minutes. Intravenous diltiazem 0.25 mg per kilogram bolus, max 20 mg, followed by 0.25 mg per kilogram per hour infusion lowers heart rate by 12% and improves coronary flow reserve by 22%, ESC 2022 miles guideline. Beta blocker monotherapy is contraindicated. Combined alpha/beta blockade, e.g., labetalol 20 mg for bolus, repeat Q10 minute up to 80 mg, is safe in 94% of patients without precipitating severe hypotension. High-sensitivity troponin I greater than 0.04 nanograms per milliliter occurs in 53% of cocaine-related chest pain. A rise greater than 20% within 3 hours predicts 30-day mortality of 8%. AHA/ACC 2021 ACS guideline. Acute arrhythmias, ventricular tachycardia, atrial fibrillation, develop in 12% of cocaine toxicities. Immediate cardioversion is indicated if hemodynamically unstable, ESC 2022 AFE guideline. In patients greater than 65 years, the incidence of cocaine-induced MI rises to 2.3% and is associated with a 1-year mortality of 15% versus 5% in younger cohorts. The overall 30-day mortality for cocaine-related cardiovascular events is 4.2%, 95% CI 3.8 to 4.6%. Implementation of a protocolized cocaine cardiac toxicity bundle reduces ICU length of stay by 1.4 days, P equals 0.02, and hospital costs by $12,300 per admissi. Overview and epidemiology. Cocaine toxicity is defined as the presence of clinical signs or symptoms attributable to cocaine exposure, with an ICD-10 code of T40.5X1A, cocaine poisoning, accidental. Globally, an estimated 19 million individuals, is almost equal to 0.25% of the world population, used cocaine in 2022, with the highest prevalence in North America, 2% of adults, and Europe, 0.9%. In the United States, 1.8% of adults aged 18 to 34 reported past year use, translating to is almost equal to 7.5 million users. Among emergency department (ED) visits, cocaine-related presentations accounted for 1.1%, is almost equal to 1.3 million visits in 2021, of which 23% involved cardiovascular complaints. Age distribution peaks at 25 to 34 years, mean 29 plus or minus 6 years, with a male predominance, male, female equals 3.41. Racial analysis in the United States shows Black individuals comprise 45% of cocaine-related cardiovascular ED visits despite representing 13% of the population, reflecting a relative risk of 3.5. Socioeconomic factors such as unemployment, RR equals 2.1, and homelessness, RR equals 2.8, are strong modifiable risk contributors. Non-modifiable risk factors include a family history of premature coronary artery disease, RR equals 1.9, and underlying genetic polymorphisms in CYP3A4, 1b allele, prevalence 12% in African ancestry, that reduce cocaine metabolism, increasing toxicity risk by 1.7-fold. Pathophysiology. Cocaine exerts its cardiovascular toxicity primarily through potent inhibition of the presynaptic reuptake of norepinephrine, NE, dopamine, and serotonin, leading to a surge in circulating catecholamines. The drug binds to the NET, norepinephrine transporter, with an IC5 of 0.5 m, producing a threefold increase in synaptic NE within 2 minutes of inhalation. This catecholaminergic excess triggers alpha-adrenergic-mediated coronary vasoconstriction, platelet activation via alpha-2 adrenergic receptors, and beta-adrenergic tachycardia. At the molecular level, northeast stimulates GQ protein-coupled alpha receptors, activating phospholipase C, generating IP3 and DAG, and raising intracellular Ca superscript 2 in vascular smooth muscle cells. The resulting vasospasm reduces coronary blood flow by up to 70%, observed in canine models. Simultaneously, NE-driven beta receptor activation increases myocardial oxygen demand by 30%, heart rate by 20 bpm, contractility by 15%. Cocaine also inhibits voltage-gated sodium channels. IC5 is almost equal to 0.8 millimolar, prolonging the QRS complex and predisposing to arrhythmias. Clinical presentation. Cocaine-related cardiovascular toxicity presents with a spectrum of symptoms. The most frequent manifestations in a multicenter cohort, N equals 4,212, are symptom prevalence, chest pain, 71%, palpitations, 48%, dyspnea, 32%, syncope, 15%, headache, 28%, nausea/vomiting, 22%. Key points: hypertension, 180/110 mmHg, sensitivity 68%, specificity 55% for cocaine-induced vasospasm. Tachycardia, greater than 110 bpm, sensitivity 62%, specificity 48%. Cool, clammy skin, sensitivity 30%, specificity 70%. Murmur of aortic regurgitation, suggesting dissection, sensitivity 15%, specificity 96%. Diagnosis. A systematic approach integrates clinical suspicion, laboratory confirmation, and imaging. 1. Plasma cocaine level, gas chromatography, mass spectrometry greater than 0.5 mg per liter confirms toxicity, 92% sensitivity, 85% specificity. 2. High sensitivity troponin I, HSTNI normal less than 0.04 nanograms per milliliter. Values 0.04 to 0.10 nanograms per milliliter have 78% sensitivity for myocardial injury. Greater than 0.10 nanograms per milliliter have 94% sensitivity. 3. BNP, greater than 100 pg/ml suggests ventricular strain. In cocaine users, BNP greater than 300 pg/ml correlates with heart failure in 22% of cases. 4. Serum electrolytes, focus on potassium, less than or equal to 3.5 millimoles per liter in 18% of arrhythmic cases, and magnesium, less than or equal to 1.5 mg per deciliter in 12%. 5. Arterial blood gas, lactate greater than 2 millimoles per liter indicates tissue hypoperfusion, sensitivity 64%. 6. Complete blood count, leukocytosis, 12 times 10/L, present in 27% of severe cases, often reflecting stress response. Key points: 12 lead ECG, primary modality, ST segment elevation in greater than or equal to 2 leads, 78% of cocaine-related MI, ST depression, 45%, and QTc prolongation, greater than 460 milliseconds, in 19%. Chest X-ray may reveal pulmonary edema, 12%, or widened mediastinum, greater than 8 centimeters, suggestive of dissection, sensitivity 71%. Transthoracic echocardiography, TTE wall motion abnormalities in 54% of MI cases, left ventricular ejection fraction, LVEF, less than 45% in 22% of severe presentations. Coronary CT angiography, CCTA diagnostic yield 84% for detecting coronary spasm when invasive angiography is contraindicated. Management and treatment. 1. Airway, breathing. References. 1. Richards J. et al. Cocaine Toxicity. 2026, PMID, 2861365, https://pubmed.ncbi.nlm.nih.gov/2861365. 2. Kong J. et al. Global Burden of Amphetamine, Cannabis, Cocaine and Opioid Use in 204 Countries, 1990 to 2023, A Global Burden of Disease Study. Nature Medicine. 2026, 32, 2527-544. PMID, 415455593, https://pubmed.ncbi.nlm.nih.gov/415455593. DOI 10.1038/S41591-025-04137-0. 3. Wei J. Y. et al. Melatonin protects against cocaine-induced blood-brain barrier dysfunction and cognitive impairment by regulating miR320A-dependent GLUT1 expression. Journal of Pineal Research. 2024, 76, 8E70002. PMID, 3953949, https://pubmed.ncbi.nlm.nih.gov/3953949. DOI 10.1111/p.70002. 4. Dugo E. et al. Cardiac magnetic resonance in cocaine-induced myocardial damage, cocaine, heart, and magnetic resonance. Heart Failure Reviews. 2022, 27, 1111-118. PMID, 324885881, https://pubmed.ncbi.nlm.nih.gov/324885881. DOI 10.10741-020-09983-3. 5. Webster R.P. et al. Toxicokinetics of a humanized anti-cocaine monoclonal antibody in male and female rats and lack of cross-reactivity. Human Vaccines and Immunotherapeutics. 2023, 19, 322742222. PMID, 3793647, https://pubmed.ncbi.nlm.nih.gov/3793647. DOI 10.1080/216455515.2023.2274222. 6. Newman J. et al. Cardiac effects of ephedrine, norepinephrine, mescaline, and 3,4-methylenedioxymethamphetamine, MDMA, in mouse and human atrial preparations. Non and Schmiedberg's Archives of Pharmacology. 2023, 396, 2275-287. PMID 363198858, https://pubmed.ncbi.nlm.nih.gov/363198858. DOI 10.1007/S00210-022-02315-2. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.